Welcome to the Deep Dive. Today we're getting into something quite interesting. It's where the body's own defense system, gets a bit confused.
Yeah, it starts attacking things it shouldn't, specifically red blood cells.
Exactly. We're going to unpack autoimmune hemolytic anemia, or AIHA.
It's basically a case of mistaken identity, but, on a cellular level, your immune system thinks your own healthy red blood cells are invaders.
And then it tries to destroy them. That process is called hemolysis, right?
Precisely.
So, learner, your mission with us today is to get a really solid, high-yield grasp of AIHA. We're aiming for the key stuff you need for revision, all the essentials, but without getting bogged down.
And we'll throw in some memory tips, maybe a mnemonic or two to help make it stick.
Yeah, definitely. We're using a great set of revision notes on autoimmune hemolytic anemia as our guide. Lots of good info in there.
Absolutely.
Okay, let's dive in then. Let's unpack this. What exactly is autoimmune hemolytic anemia?
Well, at its heart, AIHA is an acquired condition. It's where your immune system mistakenly creates antibodies, and these antibodies target your own red blood cells.
Okay.
And this attack leads to them being destroyed too early. That's the hemolysis, which then causes anemia.
So friendly fire,
No.
essentially. The body's defense force messing up its target recognition.
That's a good way to put it. And it helps to know there are two main types we talk about. First up is warm AIHA.
Warm AIHA, right?
Yeah, with this type, the antibodies are usually IgG, and they're most active at normal body temperature, around 37 degrees Celsius.
Makes sense, warm.
Right. And the destruction of these red cells, the ones tagged by IgG, mainly happens outside the blood vessels extravascularly, mostly in the spleen.
Ah, the spleen acting like a filter again.
Exactly. It spots these antibody-coated cells and pulls them out of circulation too soon.
Okay, so warm AIHA, IgG, body temp, extravascular destruction, spleen's the main player.
Yeah.
Got it. What about the other type?
That's cold AIHA. Here, the antibodies are usually a different type, IgM. And as the name suggests, they work best at colder temperatures. I think around 4 degrees Celsius.
Much colder.
And the way the red cells get destroyed is often different, too. It frequently involves the complement system.
Complement. That's that cascade of proteins.
Yeah, exactly. It gets activated and can directly punch holes in the red blood cells, causing them to rupture right there in the bloodstream. So it's often intravascular hemolysis.
Okay, inside the vessels, that's a key difference.
It is. And sometimes people with cold AIHA might get symptoms related to the cold, like Raynaud's phenomenon, where fingers and toes go white or blue in the cold.
Okay, so let's contrast. Warm is IgG, body temp, mostly extravascular in the spleen. Cold is IgM, needs lower temps, often intravascular destruction via complement. Maybe. Warm hugs, IgG. Cold snap, IgM, causes a burst.
What is this?
Something like that.
Yeah, that could work. Whatever helps it stick. And the main result of all this early destruction, whether warm or cold, is hemolytic anemia.
Because the bone marrow can't keep up.
Precisely. The red cell factory, the bone marrow, just can't produce new cells fast enough to replace the ones being destroyed. So you end up with a shortage anemia.
And you mentioned it's acquired. Does that mean it doesn't always just pop up on its own? Could it be linked to other things?
Absolutely. It can be idiopathic, meaning we just don't know the cause, but very often it's secondary.
Secondary to what, typically?
Things like lymphoproliferative disorders, cancers like lymphoma or CLL, certain infections can trigger it. And even some drugs are known culprits.
Right. So what actually makes the immune system go rogue like this in AIHA? What flips that switch?
That's the million-dollar question, isn't it? And like I said, often we just don't find a specific trigger that's the idiopathic group.
Frustrating, I bet.
It can be. But we do see strong associations with other autoimmune conditions, things like SLE lupus or ALPS, which is autoimmune lymphoproliferative syndrome.
Ah, so if the immune system is already a bit, shall we say, trigger-happy in one area.
It might be more prone to making mistakes elsewhere, yes. That seems to be the case. If we look specifically at warm AIHA again, while many cases are idiopathic, we definitely see it linked with SLE, as mentioned, also certain cancers like lymphoma and CLL, and then there are drugs, the classic example being Methyldopa.
Methyldopa, right, I remember that one. It's interesting how it overlaps with other autoimmune diseases. That seems like a key theme.
It really is. Now, for cold AIHA, the causes look a bit different.
How so?
Infections seem to play a bigger role, particularly Mycoplasma pneumonia, that atypical pneumonia, and EBV, the virus that causes glandular fever.
Okay, Mycoplasma and EBV.
Yeah. And similar to warm, certain lymphomas can be associated. But interestingly, the link with SLE is much, much weaker for cold AIHA compared to warm AIHA. That's a useful distinction.
Good point.
Now, just to step back for a second, it's really important to remember that not all hemolysis is autoimmune.
Right. If red cells are breaking down, AIHA is just one possibility on the list.
Exactly. There are other major categories. You've got genetic causes problems baked into the red cells themselves.
Like
Things like hereditary spherocytosis, where the cell membrane is faulty, or hemoglobin problems like sickle cell disease, or enzyme defects like G6PD deficiency.
Okay, so inherited issues.
Yes. And then there are acquired causes that aren't immune-related. Think physical damage, like from a dodgy prosthetic heart valve smashing cells, or direct damage from infections, or an overactive spleen hypersplenism, or other membrane problems like PNH, paroxysmal nocturnal hemoglobinuria. Even severe liver disease can cause hemolysis.
Wow, okay. So a lot to consider. Knowing those helps kind of fence off when it is likely to be autoimmune.
Precisely. It helps with the differential diagnosis, which we'll touch on later.
Okay, so thinking about AIHA specifically then, who is more susceptible to developing it? Are there clear risk factors?
Yes, there are several factors that seem to increase the risk. Having another autoimmune disorder already is a big one.
We keep coming back to that.
We do. Certain infections, especially EBV and Mycoplasma, which we mentioned with cold AIHA, then certain medications, penicillin, cephalosporins, are sometimes implicated.
Yeah.
Malignancies, particularly lymphoma and CLL, are definite risk factors. And although it's not usually a straightforward inherited disease, having a family history of AIA might suggest some kind of genetic predisposition in certain families.
Right. Maybe we can use that AIMM mnemonic you mentioned, AIM for AIHA.
Let's see. Autoimmune disorders, infections, EBV, mycoplasma, medications, penicillins, cephalosporins, and maybe another M for malignancies, lymphoma, CLL.
AIMM. That works. Captures those recurring themes: autoimmunity, infections, meds, cancers. Okay, let's get into the mechanics. How does the immune system actually destroy these red blood cells?
So the key event is these autoantibodies binding to the red blood cells. In warm AIHA, it's usually IgG.
The antibody gloms onto the cell surface.
Exactly. And that acts like a signal, a tag. It tells the rest of the immune system, hey, this cell needs to be dealt with.
The antibody is the initial mistake, the label.
Yes. And then what happens next depends partly on the type of antibody and other factors. One pathway is complement activation, leading to lysis.
That's the hole punching thing we talked about.
Right, more common in cold AIHA and often leads to intravascular hemolysis destruction within the blood vessels. The complement proteins assemble on the cell surface and basically blow it apart.
Sounds pretty dramatic.
It is, biologically speaking. The other main way is phagocytosis. This is more typical for warm AIHA and extravascular hemolysis.
Phagocytosis, cells eating other cells.
Correct. Immune cells called macrophages, especially those in the spleen and liver, recognize the IgG antibodies coating the red cells. They see the flag, engulf the red blood cell, and break it down internally.
So the macrophages are like the cleanup crew, taking out the flagged cells, mostly in the spleen.
That's a perfect analogy. So warm AIHA, tagged by IgG, eaten by macrophages mainly in the spleen, extravascular. Cold AIHA, often tagged by IgM, triggering complement to punch holes, usually in the bloodstream, intravascular.
Got it. And this happens way too fast, right? Normal red cells live for ages.
Yeah, a normal red blood cell circulates for about 120 days.
Mm-hmm.
In AIHA, these immune attacks slash that lifespan dramatically. Could be just days in severe cases.
Wow, okay, that clarifies the how. Now, what other conditions could look like AIH? What should be on our differential diagnosis list?
Good question. When you suspect AIHA, you need to rule out other things that cause hemolysis. Key ones are hereditary spherocytosis, that genetic membrane defect.
Right.
Drug-induced hemolytic anemia, where a drug is the direct trigger, not necessarily via autoantibodies. Paroxysmal nocturnal hemoglobinuria, PNH, that rare acquired disorder.
Okay.
Cold agglutinin disease, which is technically a type of AIHA but has specific features. And the hemoglobinopathies like sickle cell or thalassemia.
Can we quickly pin down a key feature for each to help tell them apart?
Sure. Hereditary spherocytosis, often a positive family history, characteristic spherocytes on the film, drug-induced. Clear link to starting a new drug, usually stops when the drug stops.
Makes sense.
PNH often presents with thrombosis, or that characteristic dark morning urine. Specific flow cytometry tests confirm it. Cold agglutinin disease. Strong association with cold symptoms, specific cold agglutinin tests. Hemoglobinopathies, usually known from childhood or family history. Specific ethnic links confirmed by hemoglobin electrophoresis.
That's really helpful, like a quick mental checklist. Okay, shifting gears slightly. How common is AIHA, say, here in the UK?
It's considered fairly rare, actually. The estimated incidence is somewhere between 1 and 3 cases per 100,000 people each year.
So not something you see every day, but definitely important to recognize.
Absolutely. And it affects all age groups, although it tends to be diagnosed a bit more often in females compared to males, and it's more common in middle-aged and older adults. But you can certainly see it in children, too.
Okay. And how does that compare to, say, sickle cell?
Oh, much rarer than sickle cell in populations where sickle cell trait is common, like those with African or Caribbean heritage.
No.
Or G6PD deficiency in people from the Mediterranean or Middle East. AIAs is more sporadic across the general population.
Got it. That context is useful. Now, the clinical side. What are the telltale signs and symptoms? What might make you suspect AIHA in a patient?
Well, a lot of the symptoms are pretty general for any kind of hemolytic anemia. Because you're anemic, you get fatigue, weakness, maybe feel breathless, look pale.
Standard anemia stuff.
Standard anemia stuff, exactly. Then, because of the increased red cell breakdown, you get jaundice, the yellow skin and eyes from the excess bilirubin, and sometimes dark urine, especially if it's intravascular hemolysis releasing hemoglobin.
Okay, tired, pale, puffed, yellow, like you said.
Yeah. You might also find an enlarged spleen, splenomegaly, because it's working overtime clearing out red cells, especially in warm AIHA. And the heart might beat faster, tachycardia, trying to compensate for the lack of oxygen.
Are there any symptoms that are more specific or maybe more severe warning signs?
In really severe rapid hemolysis, patients can get chest pain, feel dizzy, or even faint. That's obviously an emergency. Abdominal pain can sometimes happen if gallstones form from all the extra bilirubin.
A complication down the line.
Exactly. And it's always worth asking about potential triggers, new medications, recent infection, any history of autoimmune disease. On examination, besides the pallor and jaundice, feeling for that enlarged spleen is key. You'd also look for signs of underlying causes, like a rash suggesting SLE or enlarged lymph nodes suggesting lymphoma.
Right, looking for the whole picture. So if the clinical picture points towards AIH, what tests confirm it?
Okay, investigations. First, you'll do tests to confirm hemolysis is happening at all. So a full blood count will show anemia, often with a high reticulocyte count, the young red cell showing the bone marrow is trying hard.
Yeah.
Then you check markers of red cell breakdown. LDH and indirect bilirubin will be high. Haptoglobin, which mops up free hemoglobin, will be low because it's getting used up.
High LDH, high bilirubin, low haptoglobin. Classic hemolysis pattern.
Classic pattern. And the blood film under the microscope is crucial. You might see spherocytes, those small, round red cells that have lost some membrane, especially in warm AIHA, and lots of those large, bluish reticulocytes.
So those tests show hemolysis. But how do you prove it's autoimmune?
Ah, that's where the specific test comes in. The direct antiglobulin test, or DAT, also known as the Coombs test.
The Coombs test, that's the one.
That's the one. It directly detects antibodies, usually IgG or complement components, stuck onto the patient's red blood cells. A positive DAT is the hallmark of AIA.
Positive Coombs test, immune-mediated hemolysis. Simple as that.
Pretty much. It confirms the autoimmune part. There might be other findings, like usually normal platelet counts, unless it's part of a broader syndrome like Evans syndrome. You might check for cold agglutinins if you suspect the cold type, maybe an ultrasound to check spleen size. But the DAT is key for the AIHA diagnosis itself.
Okay, that makes sense. So once it's diagnosed, what are the current approaches to managing AIHA in the UK?
Right, management. The main goals are, 1, stop the immune system attacking the red cells, 2, reduce the hemolysis, and 3, manage the anemia and any complications.
How do you stop the attack?
For warm AIHA, the first step is usually corticosteroids, like high-dose prednisolone. They dampen down the whole immune system.
Steroids, okay.
Yeah.
Often the go-to for autoimmune stuff.
They are. If steroids don't work well enough, or the AIHA comes back when you lower the dose, then rituximab is often used. That's an antibody therapy that targets B cells, the cells that make the autoantibodies.
Rituximab, so targeting the source.
Exactly. Sometimes other immunosuppressants like azathioprine or cyclophosphamide are considered, but often steroids and rituximab are the mainstays. Remember, warm AIHA, steroids and rituximab, often orally.
Good mnemonic.
Yeah.
What about just general support?
Oh, absolutely crucial for both types. Folic acid supplements are important because the bone marrow is working overtime making red cells and needs folate. Identifying and stopping any potential trigger drug is vital.
Right.
And if the anemia is severe and causing symptoms like shortness of breath or chest pain, then blood transfusions are necessary. But
There's a but.
yeah, transfusions in AIHA can be tricky. The antibodies might attack the transfused red cells too, so the blood bank needs to do careful cross-matching, and you only transfuse when absolutely necessary.
Okay, use transfusions cautiously. What about splenectomy? You mentioned the spleen earlier.
Yeah, removing the spleen, splenectomy, can be an option for warm AIHA that doesn't respond well to medication. Since the spleen is where a lot of the destruction happens, removing it can help.
But not usually for cold AIHA.
Generally less effective for cold AIHA because the destruction mechanism involving complement often happens intravascularly, not primarily in the spleen. Iron might be needed if there's chronic iron loss from intravascular hemolysis, but that's less common.
And for cold AIH specifically, what's the main advice?
Keep warm. Seriously, avoiding cold exposure is the most important thing for preventing hemolysis in cold AIHA. Patients need to wrap up well in cold weather. As we said, steroids and splenectomy often don't work as well. Rituximab might be tried. And again, be cautious with transfusions. Sometimes the blood needs to be warmed first.
Right, makes sense. Avoid the trigger, the cold. So, thinking longer term, what's the prognosis like for someone with AIHA?
It's quite variable, honestly. It really depends on the underlying cause. Is it idiopathic or secondary? How severe is the hemolysis? And how well does the patient respond to treatment?
So no single answer.
No. Some people might have one episode and recover fully. Others might have a chronic condition that needs ongoing management, or it might relapse periodically. So regular follow-up is usually needed.
Okay. And what are the potential complications? Things that can go wrong, either from the AIHA itself or the treatment?
Well, the anemia itself can get severe enough to cause heart strain or require frequent transfusions, which have risks like iron overload or reactions. Because the immune system is either dysregulated or being suppressed by treatment, there's an increased risk of infections. That's a major concern with steroids and other immunosuppressants.
Yeah, always a trade-off with those drugs.
It is. If the AIHA is secondary to something like lupus or lymphoma, then you also have the complications related to that underlying disease. And the treatments themselves, especially long-term steroids, have side effects, weight gain, mood changes, bone thinning, diabetes risk.
The list goes on.
It does. And don't forget the psychological impact. Living with a chronic, unpredictable condition can be really challenging. We also mentioned gallstones from high bilirubin and sometimes iron deficiency from chronic intravascular hemolysis.
Okay, quite a few potential issues to be aware of. So let's try and wrap this up as the learner. AIHA is the immune system mistakenly attacking red blood cells.
Key features. Warm AIHA, usually IgG, works at body temp. Destruction often extravascular in the spleen. Cold AIHA, usually IgM, likes the cold, often intravascular destruction via complement.
Causes can be idiopathic or secondary to autoimmune diseases, infections like EBV or Mycoplasma, cancers like lymphoma CLL or drugs. Remember AIMM, autoimmune infections, meds, malignancies.
Pathophysiology involves antibodies tagging cells, leading to either phagocytosis by macrophages, warm, or complement lysis, cold.
Diagnosis relies on showing hemolysis, anemia, hyretics, LDH, bilirubin, low haptoglobin, maybe spherocytes, and a positive Coombs test, DAT.
Management for warm often involves steroids plus rituximab. For cold, keeping warm is key, steroids less effective. Supportive care includes folic acid, stopping triggers, and cautious transfusions.
Prognosis varies. It could be chronic or relapsing, and complications can arise from the anemia, the underlying cause, or the treatment, especially infections.
Absolutely. And perhaps a final thought. This deep dive into AIHA really highlights that tightrope walk our immune system performs. It makes you think, doesn't it, about how many other diseases might stem from similar wires getting crossed. And there's still so much research going on to figure out how to better manage these complex immune conditions.
That's a great point to end on. And for all of you revising for the MSRA, remember to check out pastmsra.com and also freemsra.com for loads more resources. Thanks so much for joining us on this deep dive today.